Welcome to the deep dive. Today we're tackling hyperthyroidism, basically. What happens when your thyroid gland goes into overdrive and, how that affects the whole system.
Yeah, it's quite a common issue, actually.
It is. And we've sifted through a range of sources for you on this one, really trying to pull out the essential information.
The high-yield stuff.
Exactly.
Mm.
Our mission today is pretty straightforward. Give you a clear, memorable rundown of hyperthyroidism for revision. So we're talking definition, causes, who's at risk.
The mechanisms behind it, how you spot it.
And, crucially, how it's managed. Plus, we've got some handy memory aids lined up to help it all stick. Okay, let's unpack this.
Sounds good. So in simple terms, hyperthyroidism is when the thyroid gland pumps out too much thyroid hormone, specifically, we're talking T3 and T4.
Right.
And this excess, well, it really revs up your metabolism, leads to a whole cascade of effects throughout the body.
And it's useful to think about primary versus secondary. Right.
Definitely. So primary is a direct issue with the thyroid gland itself. Like it's just decided to work overtime on its own schedule.
Got it.
Secondary hyperthyroidism, though, that's different. That's when the thyroid is being sort of pushed to produce more hormone because there's too much TSH, thyroid stimulating hormone.
Which usually comes from the pituitary gland.
Exactly, yeah. Usually a pituitary issue.
And the most common reason for the primary type, especially where people get enough iodine, that's Graves' disease, isn't it? And it's more than just a thyroid thing?
Absolutely. Graves' disease is it's autoimmune. Your body mistakenly makes these antibodies that basically act like TSH. They just keep telling the thyroid, make more, make more.
Non-stop signals.
Pretty much. And what's really interesting or maybe problematic is that these antibodies don't just hit the thyroid. They can target other tissues too. That's where you get those extra thyroidal effects we see in Graves, especially the eyes and sometimes the skin.
Ah. So it's a wider autoimmune response?
Precisely. It's systemic.
Okay, so let's get down to brass tacks. What are the main reasons someone might end up with an overactive thyroid, the different etiologies?
Well, top of the list, like we said, is Graves' disease. That's number one.
Right.
Then you've got something called toxic multinodular goitre. So picture the thyroid gland getting bigger, developing several lumps or nodules.
Okay.
And these nodules start churning out thyroid hormones all on their own, independent of TSH. You see this more often in older people.
And similar to that is a toxic adenoma.
Yeah, very similar concept, but here it's just one single rogue nodule doing the overproducing.
Just one troublemaker.
Exactly. Another key cause is subacute thyroiditis. This is basically inflammation of the thyroid.
Right.
And that inflammation causes stored thyroid hormones to just leak out. So you get this temporary burst of hyperthyroidism.
Temporary, right.
Usually, yes. One specific type is Quervain's thyroiditis. Often follows a viral infection. Can be quite painful neck tenderness, maybe a fever. But the hyperthyroidism itself is usually transient.
And I know certain medications can trigger it too.
That's right. Amiodarone is a big one.
For heart rhythm issues.
Yeah, it's packed with iodine, and it can really mess with thyroid function sometimes, causing hyper or even hypo.
Interesting.
And then less commonly, you might see hyperthyroidism caused by thyroid cancer, though that's rare, or tumors in the pituitary or hypothalamus that disrupt that whole TSH regulation pathway.
Okay. And focusing back on Graves' for a second, it's those TSH receptor antibodies doing the damage.
Yes, they're the key. They bind to the receptors, constantly stimulate hormone production, and that often leads to that enlarged thyroid, the goitre, and sometimes those very distinctive eye signs.
Whereas the toxic nodular goitre is just the nodules themselves going rogue, no immune attack.
Exactly. It's driven by these autonomous nodules just doing their own thing, no Graves features.
And the toxic adenoma is even more localized, just that one nodule.
Correct. You can often feel it.
Yeah.
And, we should probably mention a few other less common causes, too. Well, people taking too much thyroid hormone medication themselves, sometimes intentionally, sometimes not. Certain drugs like lithium can affect the thyroid. Very high iodine intake in some susceptible people. And in really rare cases, follicular thyroid cancer that's spread, or even certain ovarian tumors, teratomas that can actually produce thyroid hormone.
Wow, okay. So are some people more likely to get hyperthyroidism?
Yeah.
What are the main risk factors?
Definitely. Family history is a big one. If thyroid problems run in the family, your risk goes up.
Makes sense.
Also, being female significantly increases the risk compared to men.
Right.
And having other autoimmune conditions like type 1 diabetes or rheumatoid arthritis, that bumps up the risk too.
Right.
And a history of radiation exposure, particularly to the neck area, especially in youth.
What else?
Well, beyond those, a really high intake of iodine can sometimes be a trigger. Smoking is an interesting one. It's particularly linked to the eye problems in Graves' disease, making them more likely and more severe.
Mm.
Trauma or surgery involving the thyroid gland can occasionally play a role. For toxic multinodular goitre, things like long-term high iodine exposure or certain meds might contribute. Even the period after childbirth, the postpartum period, and using HAART, the HIV treatment, have been flagged as potential risks in some studies.
You mentioned genetics and the immune system earlier. Can you expand on that a bit?
Absolutely. So there are specific genes, things like HLA genes, CTLA4, PTPM22. These are all involved in how our immune system works.
Right.
And variations in these genes have been linked to a higher chance of developing autoimmune thyroid diseases, like Graves'. It really highlights how closely the immune system and thyroid function are intertwined.
So if you have one autoimmune condition,
Your risk for another, like Graves', is higher, and family history of autoimmune disease also plays a part. And like we said, smoking seems to pour fuel on that fire, especially for the eye disease component of Graves'.
okay, let's dive into what's actually happening inside the body, the pathophysiology. This is where it gets really interesting.
You're right, it is. Because this explains why you get such widespread effects. The core issue is too much thyroid hormone leading to hypermetabolism. Basically, everything speeds up.
Right.
In Graves', the key actors are those thyroid-stimulating immunoglobulins, or TSIs. These antibodies latch onto the TSH receptors on the thyroid cells.
And just keep pressing the on button.
Exactly, telling the thyroid to keep churning out T3 and T4. That overstimulation also causes the gland itself to grow. That's the goiter.
Okay. And for the toxic nodules?
Slightly different mechanism. In toxic multinodular goiter and toxic adenomas, you have these nodules within the thyroid that have become autonomous, meaning they produce thyroid hormones completely independently of TSH. They don't need the signal from the pituitary anymore. They've sort of developed their own internal on switch that's stuck on.
Ah, I see.
And the result in both Graves' and toxic nodules is these elevated thyroid hormone levels circulating around the body. And because thyroid hormones affect almost every organ system,
You get that huge range of symptoms.
precisely, it impacts everything from your heart rate and digestion to your mood and energy levels.
So maybe a quick refresher on how the thyroid normally works would help cement why this disruption is such a big deal.
Good idea. So the thyroid gland sits in your neck, right? Its main job is controlling your metabolic rate, how fast your body uses energy.
Okay.
Its activity is regulated by TSH from the pituitary gland in the brain, and the pituitary gets its instructions from TRH, which comes from the hypothalamus, also in the brain.
It's chain of command.
Exactly. Hypothalamus tells pituitary, pituitary tells thyroid. So TSH hits the thyroid and stimulates it to make T4, thyroxine, and T3, triiodothyronine.
T3 and T4.
Right. The thyroid makes mostly T4, but T3 is the more potent biologically active form. A lot of T4 gets converted into T3 in other tissues around the body.
And they travel in the blood.
Yes, mostly bound to proteins. Only the small free fraction is active. And critically, there's a negative feedback loop.
Ah, the control system.
Yeah. When free T3 and T4 levels rise, they signal back to the hypothalamus and pituitary saying, okay, enough. Slow down TRH and TSH release. This normally keeps hormone production in check.
But in hyperthyroidism, that feedback loop is broken.
Exactly. It's overridden either by those stimulating antibodies in Graves's or by the autonomous nodules just ignoring the signals altogether.
That makes perfect sense. Now, when a doctor suspects hyperthyroidism, what else might be on their mind? What other conditions could look similar? The differential diagnosis.
Yeah, that's important because other conditions can cause similar symptoms, often related to increased metabolism or sympathetic nervous system activity.
Like what?
Well, one key thing to consider is pheochromocytoma. It's a rare adrenal gland tumor
Adrenal glands, okay.
that pumps out excess adrenaline and noradrenaline catecholamines. So you get symptoms like rapid heart rate, sweating, anxiety.
Sounds a bit like hyperthyroidism, right?
It does, yeah. Also, other adrenal issues like Cushing's syndrome or hyperaldosteronism can sometimes have overlapping features. And finally, certain medications, especially sympathomimetics drugs that stimulate that fight-or-flight response, can mimic some hyperthyroid symptoms.
So ruling those out is key. How common is hyperthyroidism overall? What's the epidemiology look like?
In the UK, the estimates are around 1 to 2% of adults will have it at some point.
Okay.
And as we've said, Graves' disease is the most common cause. It can happen at any age, but it's much, much more common in women.
Right.
Looking across Europe, the incidence of thyrotoxicosis, that's the clinical state of having too much thyroid hormone, is maybe around 1 in 2,000 people per year.
in older people?
Interestingly, actual undiagnosed overt hyperthyroidism seems quite rare in people over 65, maybe 0.3%, but subclinical hyperthyroidism.
Where the TSH is low, but T4, T3 are normal?
Exactly. That's more common in older adults, maybe around 2%. People might not have obvious symptoms.
Gotcha. And Graves specifically?
Affects about 2% of adult women, but only about 0.2% of adult men. So quite a big difference there. And while it's mostly adults, kids can get it too. Maybe 1 to 5% of all Graves' cases are in children.
Okay, let's shift to the patient experience. What does hyperthyroidism actually feel like? What are the typical signs and symptoms people report?
It can really vary, but there are some classic things. Unintentional weight loss is very common, often despite eating more.
The appetite goes up.
Often, yes. Though sometimes appetite can decrease, or people might even gain weight. It's not totally predictable. Irritability, anxiety, feeling on edge, that's very common. Fatigue and muscle weakness, too, paradoxically. Despite feeling sped up, people often feel tired. Changes in bowel habits, often diarrhea, sometimes oily stools.
Okay.
Sweating more than usual, even when it's not hot. A fine tremor, often noticeable in the hands.
Like a shaky feeling.
Exactly. And mental health can be significantly affected from anxiety and nervousness, maybe panic attacks, up to, in rare cases, psychosis. Heat intolerance is a big one, feeling hot when others are comfortable.
Right.
Loss of libido is common. And women might notice changes in their periods becoming lighter or less frequent or stopping altogether.
And what might a doctor notice on examination? The signs.
Well, they might see palmar erythema red palms, which might also feel warm and sweaty.
Okay.
That fine tremor is often visible if you ask the patient to hold their hands out. The heart rate is usually fast tachycardia. And in older people, this can sometimes trigger atrial fibrillation or even heart failure.
Serious stuff.
Yeah. Hair might be thinning, or there could be diffuse hair loss. Some people get urticaria hives or complain of itching. Reflexes are often unusually brisk. A goitre, that enlarged thyroid, is common. You might feel it or see it in the neck. Proximal myopathy is another sign weakness, sometimes with muscle wasting, especially in the upper arms and thighs.
Okay.
In men, gynecomastia, enlarged breast tissue, can occur. And lid lag, where the upper eyelid lags behind the eyeball when looking down, that can happen with hyperthyroidism from any cause.
And you mentioned some signs are specific to Graves.
Yes, Graves has its own unique set. Graves' ophthalmopathy, or thyroid eye disease.
The bulging eyes.
Yes, exophthalmos is one sign, but it's inflammation around the eyes causing bulging, double vision, discomfort, redness. Also, the thymus gland in the chest can sometimes be enlarged. And pretibial myxoedema.
That's the skin thing.
Right. Thickened, swollen skin, usually on the shins, kind of an orange peel texture. And Graves can sometimes be linked with other autoimmune issues, liver problems, low platelets, pernicious anemia.
Wow.
We should also mention thyrotoxic periodic paralysis. Not common, but serious. Sudden episodes of muscle weakness, paralysis even, linked to low potassium levels as potassium shifts into cells.
Okay.
And then there's the big one. Thyrotoxic crisis or thyroid storm.
The emergency situation.
Absolutely. Rare, maybe 1–2% of patients, but life-threatening. It's an extreme worsening of symptoms. Very high fever, confusion, agitation, rapid heart rate. Really exaggerated thyrotoxic signs. Can be stopping antithyroid drugs suddenly, radioiodine treatment, a bad infection, surgery. Management is urgent, fatty fluids, beta blockers, antithyroid drugs, steroids, and you need to check for Addison's disease too. Mortality is high, sadly 20–30% often from heart problems or the hyperthermia.
That sounds incredibly serious.
Yeah.
Okay, so moving to diagnosis, how do doctors confirm it's hyperthyroidism? What tests do they use?
The absolute key is blood tests for thyroid hormones. The first test almost always is serum TSH.
Thyroid-stimulating hormone.
Right. And in almost all cases of primary hyperthyroidism, the TSH will be low, suppressed, because all that excess T4 and T3 is telling the pituitary to shut up, basically.
Negative feedback.
Exactly. Then we measure the actual thyroid hormones, free T4 and free T3, or sometimes total levels. In overt hyperthyroidism, these will usually be high.
Usually both.
Usually. But sometimes you see patterns, like T3 toxicosis, TSH is low, T3 is way higher than T4. That's quite common in Graves's.
Okay.
Or T4 toxicosis, low TSH, high free T4, but T3 might be normal. You can sometimes see that if someone has another illness going on too.
And subclinical.
That's low TSH, but free T4 and T3 are still in the normal range. Often no symptoms, but not always benign.
And rarely the TSH is not low.
Very rarely, yes. TSH-induced hyperthyroidism. TSH might be normal or even high despite high T4, T3, usually due to a TSH-secreting pituitary tumor or resistance to thyroid hormone feedback, but that's uncommon.
Are there other tests to help figure out the cause?
Oh yes, definitely. Autoantibodies are very helpful, anti-TPO, anti-thyroglobulin antibodies, but the really specific one for Graves is the TSH receptor antibody. If that's positive, it's pretty much a diagnostic for Graves.
Right.
Imaging can also help. A thyroid ultrasound shows the gland size, structure, any nodules.
Hot or cold nodule.
Exactly. A thyroid uptake scan, usually with a tiny bit of radioactive iodine, shows which bits of the thyroid are active. Hot nodules are overactive, cold ones aren't, and might need checking for other things.
Okay.
And if you suspect subacute thyroiditis, inflammatory markers like CRP and ESR might be raised.
So once it's diagnosed, what's the plan? How is hyperthyroidism managed?
The main goal is straightforward. Get those thyroid hormone levels back to normal and relieve the symptoms.
Makes sense.
And there are really three main treatment pillars: antithyroid medications, radioactive iodine therapy, and thyroid surgery.
Okay.
Which one is best depends on lots of things. The exact cause, the patient's age, their health, how big the goiter is, and importantly, the patient's own preference after discussing the pros and cons.
And monitoring is key.
Absolutely essential. Regular blood tests to check hormone levels are needed to make sure the treatment's working and adjust doses as needed.
Let's dig into those options. What about the medications?
So antithyroid drugs, carbimazole is common in the UK. Propylthiouracil, PTU is another one. They work by stopping the thyroid from making new hormone.
Okay.
You usually start with a higher dose to get things under control quickly, then reduce to a lower maintenance dose. Sometimes doctors use a block and replace approach, high-dose antithyroid, to completely block production, then add back a small dose of levothyroxine, synthetic T4.
To avoid hypothyroidism.
Exactly. And for symptom control, the fast heart rate, tremors, anxiety beta blockers like propranolol are really helpful, especially early on.
And surgery, when is that considered?
Surgery thyroidectomy, removing part or all of the thyroid might be chosen for specific reasons. Maybe a very large goiter causing pressure symptoms, or if there's a suspicion of cancer. Also in women planning pregnancy soon, or if radioactive iodine isn't suitable or desired.
Okay. And the radioactive iodine, how does that work?
Radioactive iodine therapy is very effective. The patient takes a capsule or drink with a small, safe dose of radioactive iodine.
I-131, usually.
Yes. The thyroid gland naturally takes up iodine, so it concentrates this radioactive iodine. The radiation then destroys the overactive thyroid cells over weeks to months.
So it shrinks the gland and reduces hormone production.
Exactly. It often leads to permanent hypothyroidism down the line, though, so most people will need lifelong thyroxine replacement afterwards.
So it's a trade-off.
It is, and surgery is generally preferred, like we said, in pregnancy, big goiters, low iodine uptake, suspected malignancy, or patient preference.
So summarizing the approach: diagnose with symptoms and TFTs, check for urgent issues like storm, talk through options with the patient, start maybe carbimazole plus a beta blocker, monitor closely, and then decide on the definitive path: meds, radioiodine, or surgery. What about those rarer types?
Right. Secondary hyperthyroidism is usually a pituitary problem like a TSH-secreting adenoma, or other rare causes like thyroid hormone resistance or certain tumors producing HCG, or sometimes transiently during pregnancy.
And subclinical, low TSH, normal T4, T3.
Yeah, that's interesting. Many are asymptomatic, but there is an increased risk of things like AFib and maybe fractures in older adults. So treatment, often radioiodine or maybe long-term low-dose carbimazole, might be considered, especially if TSH is very low or if the person has risk factors.
Neonatal.
Rare happens if the mother has Graves and her antibodies cross the placenta. Needs specialist management. Childhood hyperthyroidism is less common than in adults. More often in girls, managed similarly.
And the amiodarone issue.
Ah, yes, amiodarone-induced thyrotoxicosis. Amiodarone can cause both hyper and hypo. Managing the hyper type can be tricky. Depends if it's due to excess iodine or an inflammatory thyroiditis. Might involve stopping amiodarone if feasible. Antithyroids, sometimes steroids, needs careful handling.
What's the long-term outlook usually like? The prognosis.
Generally, it's very good if it's diagnosed and managed properly.
That's reassuring.
Yeah. The treatments we have, meds, radioiodine, surgery, are effective at controlling or curing it. The key is getting the right treatment and sticking with it.
And if it's not treated?
Well, that's where the problems arise. Untreated hyperthyroidism can lead to serious complications like osteoporosis, heart problems, arrhythmias, heart failure, and of course that dangerous thyroid storm. So follow-up and sticking to treatment are really crucial.
Let's talk a bit more about those complications. What specifically can go wrong long-term?
Okay. Osteoporosis is a big one. Excess thyroid hormone speeds up bone turnover, leading to weaker bones and increased fracture risk.
Right.
Cardiac arrhythmias, especially atrial fibrillation, AFib, are much more common. AFib increases stroke risk. Heart failure can develop, especially in older people or those with existing heart issues.
And thyroid storm, we covered that emergency.
Yes, the most severe acute complication. High fever, tachycardia, confusion, organ dysfunction, life-threatening.
Sure.
So overall, untreated hyperthyroidism can really damage the cardiovascular system, bones, nervous system.
Proper management prevents these?
Largely, yes. Diagnosis, effective treatment, and ongoing monitoring are key to preventing these complications and keeping people well. So what does this all mean for someone trying to get their head around hyperthyroidism?
Well, it means it's relatively common, definitely needs attention. Careful diagnosis, finding the cause, and getting the right management are vital to rebalance hormones and avoid those serious issues. Really shows how interconnected everything is, doesn't it?
It really does, how one small gland can have such a massive impact.
Okay, to help cement all this, let's run through some memory aids and quick questions.
Sounds good. So, for remembering common symptoms, think sweating.
Sweating.
Sweating, weight loss, emotional lability, mood swings, appetite increase, tremor, intolerance to heat, nervousness, and goitre.
Sweating. Got it. Okay, quick question for you listening. A 35-year-old woman comes in, lost weight despite eating more, heart's racing, feels hot all the time. What's the first blood test you'd likely order?
And the answer would be serum TSH.
Spot on.
Now, for Graves' disease features, you can use GET,
Yes.
goitre, eye signs like exophthalmos, tachycardia, and skin changes, specifically that pretibial myxoedema.
Get CS for Graves.
Okay,
And another question, which antibody is most commonly elevated in Graves' disease?
that would be the TSH receptor antibody.
Perfect.
And for thyroid storm symptoms, maybe think hots and mad.
Hot and mad.
Hyperthermia, high temperature, tachycardia, fast heart rate, and mental status changes agitation, delirium, basically APD.
HOT and ND.
Yeah.
That's memorable. If grim. Last question then. What's a common first-line medication for a newly diagnosed, non-pregnant adult with hyperthyroidism?
Usually carbimazole in the UK.
Excellent.
So wrapping up our deep dive on hyperthyroidism, we've covered what it is, the many causes, the risks, how it works, how it's diagnosed and treated, the prognosis, and those potential complications.
Yeah, it really hammers home how one overactive gland impacts the whole body.
Yeah.
And, it makes you think about the immune system's role, especially in Graves, and just how complex these things are. If you want more detailed resources to really master topics like hyperthyroidism, definitely head over to passthemsfa.com.
And for even more free study materials and useful content, don't forget to check out freemsara.com.